Hi, I'm Rui Pereira da Costa, organizer of the Endo Masters 2015. No doubt we're having a full Endo day, but there's still much ahead. Our next lecture will start a new series of lectures dedicated to the resolution of endodontic failures, and it will be presented by my friend Carlos Bueno from Brazil. Carlos is a professor of endodontics at the Catholic University of Campinas and coordinator of the graduate program at the São Leopoldo Mandic, Campinas, Faculty of Dentistry, including Master of Science and PhD program. He has published the amazing number of 104 articles in peer-reviewed journals and 4 textbook chapters. Carlos is a reviewer for the Journal of Endodontics and International Endodontic Journal, and currently he is the Vice President of the Brazilian Endodontic Society. It is then a great honor to have such a distinguished speaker who will present a lecture on endodontic retreatment predictability, certainly a topic that is indispensable to all that do endodontics. See you soon.
Hi everyone. First, I would like to thank Dr. Rui Pereira da Costa for organizing this event, which is the biggest online congress in our area. It is a great pleasure to be participating in this meeting with other professors of several countries. I think that is an excellent opportunity to improve our knowledge in endodontics. My lecture is about endodontic retreatment and the new concepts in this area, allowing better results in our procedure. I am the coordinator of Campinas Endodontic team, which offers courses in endodontics from the undergraduate level up to the Master of Science and doctoral degrees. The team was founded in 1996. We have acting in São Leopoldo Mandic, Faculty of Dentistry and Medicine. Our studies work with dental operating microscope most of the time, mainly in retreatment procedures. In addition, I have been working part-time for 26 years in private practice in Campinas, near to São Paulo, the biggest city of Brazil. I have been daily using dental operating microscope since 1995, when I attended a very special course of excellent Dr. Gary Carr in AAE meeting. This course allowed me to develop knowledge on this technique and make documentation of my clinical cases. Before going over retreatment procedures, I would like to speak about causes of endodontic failure. First cause, and I think the most important, is microorganisms that resist the endodontic treatment. I highlighted this topic in green, and I will use an article from my colleagues, Siqueira and Roças from Brazil, to explain about this issue. The authors stated that bacteria must multiply to a certain number in order to become pathogenic and provide conditions to the infection, normally with the presence of signs and symptoms that are characteristic of the disease. The success of endodontic retreatment depends on the reduction this number of bacteria to below the limit. In order to achieve this objective, we need an extensive preparation from the mechanical and chemical perspectives. This article shows that there are more virulent species of bacteria in retreatment cases than in treatment. For example, Enterococcus fecalis and Actinomyces israeli, which is an example of bacteria that are able to survive outside the root canal system. Furthermore, many species are not cultivated in the laboratory tests we have nowadays. This case is very interesting. It's not exemplary of excellent retreatment, but it is able to demonstrate that when we get to significantly reduce the number of bacteria, it is possible to obtain success on the endodontic treatment, sometimes even without reaching the canal along the entire length. A root perforation was made when I attempted to return to the original canal route. Analyzing this 6 months and after 1 year post-treatment, it is possible to observe the partial bone formation. I believe this case shows the evidence of success, but it is necessary to make new controls. The second issue is regarding failure in endodontics when involving the anatomy. This is a very important point, especially missed canals, which is more prevalent on retreatment. Also, certain groups of teeth present more missed canals. The first molar upper tooth is more prone to present this issue than other teeth because the MB2 canal is narrower and difficult to negotiate with. In this case, my referring dentist observed only 2 canals in the panoramic X-ray. Of course, not a good choice to analyze quality of root canal treatment, this kind of X-ray. We did a crown, and after 1 year, the patient had a swelling in the mucosa above the premolar tooth and the pain. The examination of the X-ray, periapical X-ray, shows the missed canal, and because that, a CBCT was done. This video was done with the axial sections and demonstrates clearly the presence of the distal buccal canal. After that, the tooth was retreated and the canal was found. It's possible to observe in this image the hypodensity area upper the tooth. In these pictures, we see the removal of the post with ultrasonic procedure, and I will explain this technique on the following slides. On the top image, we see the exact moment when the root canal was found, named distal buccal canal. This kind of premolar resembles a little molar. The final X-rays in 2 different angles show that the 3 canals were obturated. This is a very special case for me because I made the first treatment but couldn't negotiate the mesial buccal and the mesial buccal 2. This is the final X-ray. The patient came back after 5 months reporting pain when stimulated with finger pressure. On this second retreatment, I requested a CBCT scan, but should have asked for it on the first instance. The results are in this video. We observe that it is possible to treat this missed canal, the MB, because it has a hypodense image in the root that we can see in the axial section. After the CBCT visualization, I could understand that I was looking for MB2 at incorrect position. On a second attempt, based on tomography, I was able to find the MB2. More resistant RAND files as C-Pilot from VDW and C+ from Dentsply were used in this case. The final X-rays shows the treatment of these missed canals, including the MB2. This article by Wolcott and co-workers analyzed fails to locate the MB2 either on initial treatment or retreatment. Located in B2 is more prevalent in this study on retreatment, indicating that many dentists don't properly search for this canal in the first treatment. These numbers are impressive to me, and I believe dentists should better watch for the MB2 on the first treatment. The third point is the vertical root fracture. I consider it is one of the most frustrating complications of root canal treatment. We should keep attention for this issue since the diagnosis is eventually done incorrectly. Some characteristics are frequently present in vertical root fracture, as deep and narrow periodontal pocket pain during mastication and slight tooth mobility, swelling near the area where the post is. To confirm the diagnosis, we observe this area in dental operating microscope, applying methylene blue 1% with a micro brush on the suspected crack area. In these situations, the choice is the tooth extraction, only possible this choice. However, in some cases, the crack is not easy to perceive, and dentists will perform the endodontic retreatment. In face of this situation, the retreatment won't have success. This is a very unique article by Gorn and Gagliani, where they stress the importance to understand the anatomic problem we have when performing root canal retreatment. When it's possible to reach canal patency until the foramen, the success rate increases. In this study to 868.8%, but contrary, if we can get the canal patency, the success rate decreases to 51.07%. Therefore, it is important to be able to reach the end of this canal, surpassing filling material, deviations, and other difficulties they may exist during the process. Our group realized foramen patency in all cases in order to permit that foramen is free of debris, pulp, and bacteria. I always joke saying that I wanna be in the foramen, removing pulp, filling material, everything that prevents from reaching up to foramen. This study will demonstrate how often we cannot remove all the filling material from the first treatment. For this reason, it makes necessary to study more effective techniques in removing gutta percha. Only of the ways to remove the remaining material is to use dental operating microscope. And I could say it is the best way to remove small pieces of gutta percha caught in the root walls. The determination of the need for root canal retreatment usually occurs when the dentist asks for a set of periapical X-rays. It is possible to observe chronic lesions in periapical area. Symptomatology for than 1 month is other factor that leads to endodontic retreatment. Another important point is to evaluate if crown or restoration will be done after the endodontic retreatment. If the case necessitates the prosthetic crown, The endodontic treatment has to be in perfect condition. If the tooth does not have signs and symptoms and only needs a restoration, a control of the case can be realized. Finally, the first choice when endodontic treatment fails is conventional retreatment in order to eliminate the infection that is inside the canal. Basically, we can divide the retreatment process into 5 steps, but in this lecture, I'm going to cover the access to root canals, removal of restoration and posts, as well as desobturation and reinstrumentation of root canals. When we need to remove restorations of the crown, it is very interesting to use ultrasonic tips to do this work. Particularly, I like using Start X number 3 from Dentsply and B&L number 2 from Biotech. You need to make brushing movements to remove the resin and porcelain in the excess area, like this case, initial X-ray and final X-ray. The most difficult step is the access to the foramen, including gutta percha removal and sometimes removing post of root canals. Gutta percha removal can be time-consuming and can cause fatigue that may lead to procedural errors. Oval and longo-oval root canals offers an additional challenge to the removal of the previous filling material. There is a tendency to keep the file in the center of the canal, which does not allow adequate preparation, for example, in the buccolingual dimension. When previous filling material is not completely removed, it acts as a barrier, preventing the irrigation solution from touching the canal walls. Remaining filling material also can harbor necrotic tissue and microorganisms responsible for endodontic treatment failure. Numerous studies have continuous evaluating filling material removal, conventional night-eye rotary files, and now reciprocant files can be used to remove filling material like this. They present the advantage to avoiding the removal of excessive tooth structure as it often occurs when using gate gliding drills. The postulate idea that the use of organic solvents is necessary for the removal filling material can be considered inappropriate. Several published articles demonstrate both root filling remains on the root canal surface as well as the formation of an artificial smear layer after using these agents. Further disadvantage is the cytotoxicity, which is especially of concern when they are extruded into the periapical area. This study from Horvath et al. Demonstrates the cleanliness of canal walls after gutta percha removal with and without solvents in scanning electron microscope. We observed that solvents left more gutta percha remains on the canal's walls. Therefore, their use should be avoided. This is a clinical image of this fact. In certain cases, the hardening of the sealer is accentuated to such a degree that it is very difficult to remove the gutta percha in the fullness or even establish a glide path through the gutta percha, especially in curved canals. I studied solvents for a few years, allowing me to report that chloroform is the most effective organic solvent. Valdriga and I concluded on this study that chloroform was more effective than other tested solvents regarding weight loss of gutta percha points. Some studies showed that chloroform has high cytotoxicity potential, but McDonough and Weyer, 1992, found that chloroform, if used under normal conditions, does not cause any irreversible cytotoxic effects. This study, developed by our team, was one of the pioneers in demonstrating the use of rotary instruments like ProTaper D, especially designed to realize the remotion of endodontic material. This study concluded that all techniques removed similar amount of gutta percha, but the ProTaper D without solvent was faster. What is the justification for this result? When the solvent is used, the artificial smear layer is formed, and this fact complicates the remotion, even when using microscope. Also, we did a study to compare combination Rand files gates gliding plus ultrasonic tips with magnification provided by dental operating microscope, and other group only with hand files and gates gliding. The protocol with microscope and ultrasonic was more effective than other group. Therefore, it is very interesting to use microscope and ultrasonic in retreatment cases. The concept of using microscope and ultrasonic together is called microsonics, in actual, well-established procedure. The graphic depicts the results from the previous study. The group in which was used the microsonic approach presented lower amount of remaining material from a aesthetical point of view. Nowadays, there are other systems on the dental market with the same proposal. One of this system is M2R from VDW, but the results in the literature haven't been good as ProTaper D. What are the advantages to use rotary or reciprocant systems in retreatment? From my perspective, the main advantage is to maintain the center of the root canal and increase the elimination of debris through the escape area of the rotary instruments. Some characteristics from ProTaper D should be watched over. D1 has an active tip which enables to produce a perforation in the root canal walls. Our group personally never used this instrument. Instead, we started the desobturation process with gate gliding number 2. When using the ProTaper D2, in and out movements and brushing must be applied 3 times per use, following irrigation with sodium hypochlorite. This procedure is repeated until a sensation of clean canal is found without debris. Number 3, is used in apical third with the same approach. This slide shows if there is still gutta percha inside the canal, it is necessary to use hand files as C+ or C pilot, which are more resistant to reach the apical foramen. On the other hand, for D2 and D3, we use the speed of 400 RPM and the torque is 4 newtons. We use these instruments for up to 4 cases. In this video, we watch the in, out, and brushing movements performed with these instruments. This is very important point. Together with co-workers, we have recently published some papers that evaluated the efficacy of single-file reciprocant system in removal of filling material. The advantages of these systems include that MY are more resistant alloy and the fact it is a single file. A traditional retreatment system like ProTaper-D requires 3 instruments for removal of gutta percha. The disadvantage is that the tip 25 and the taper 8 in the first millimeters might be a little large for some cases, while ProTaper-D 3 is a 20 tip and taper number 7, the first millimeters. A recent study developed by our group tested 3 different systems, manual files, reciproc, and M2R in extract uniradicular teeth. As a result, the reciprocant and manual techniques presented better results than M2R. Furthermore, reciproc was faster than the other systems. This paper is a comparison of reciprocant and rotary system on their ability to remove filling material. An important aspect of this study is that solvent was not used, which, in our opinion, it is a tendency in the current techniques for retreatment. Data from this research showed reciprocant system as efficient as ProTaper are in removal of gutta percha and sealer. In this study, microtomography was used on the evaluation of residual material in curved canals. It compared reciproc and wave 1 with and without a complementary technique adding xylene to conventional passive ultrasonic irrigation. Data of the 3/3 of specimens confirmed that the efficacy of both systems. However, it did not completely remove the root canal filling. In spite of the lack of the success of passive ultrasonic irrigation in this paper, the use of sodium hypochlorite instead of solvent should be better evaluated in the future studies. The reciprocant technique for retreatment is very similar to that used for root canal shaping. A great advantage is that solvent is almost unnecessary because the movement of this file and these frictions facilitates the removal of filling material. In and out movements are done with slightly bigger apical pressure than in treatment and with brushing action during the removal of instrument. Copious irrigation helps removal of gutta percha and these situations. Specific ultrasonic irrigation technique enhances efficacy of removal. This video shows the in and out technique of reciprocant system with brushing action. Sodium hypochlorite was used in this upper molar. The clinical situation shows the preparation from middle to apical third. It is interesting to see how the gutta percha displaces from the root canal walls in small blocks. At the apical third, a loose file confirms the removal of material. In this case, the periapical X-ray is misleading. During CBCT, it was possible to note that MB2 wasn't treated, resulting in a formation of a great hypodense area. Furthermore, it was possible to observe a swelling of the buccal mucosa. In this CBCT video, we can observe on axial sections that the MB2 canal wasn't found in the first treatment. After removing the post inside the palatine canal, also in distal buccal, the preparation of the root canals was done. In the first section, it was notorious the presence of purulent exudate in MB2. The final X-rays shows the retreatment with 4 canals obturated and provisional prophylaxis and post. After the endodontic retreatment, a second dentist did a surgery in the apical area to remove the lesion with cystic aspect. This is another case in which I used wave 1 for removal of gutta percha from the distal canal and ultrasonic tip to gain access to the root canals MB and ML. Also, I used the hand files C+ because the mesial canals were very narrow and C+ is especially made for these cases with active tip taper 0.4 in the first millimeters, which makes it more resistant. These pictures show all the canals with the access obtained up to the foramen. It is very difficult to make this. The initial X-ray and the final X-ray of this case. The diagram brings the idea of the importance in considering the use of solvent or not. If the case presents easy in removing gutta percha from the canal, then a treatment with no solvent is the best choice. When existing curvature in the root canal and it is difficult to remove gutta percha, eventually it's necessary to use solvents. Also, it is important to have access to the technological apparatus as ultrasonic device. The success in the treatment of calcified or atresia canals is dependent on knowledge of anatomy and observation of reference anatomic points. In complex case, a CBCT should be used for clarification. Moreover, there are new files dedicated for initial catheterism in atresia canals, such as the C+, as already mentioned, or the C-pilot file with a constant taper 2 in the first millimeters, but with a surface treatment which increases file resistance. Ultrasonic tips such as BL and StartX are helpful instruments that aid the entrance of calcified canals. For sure that the use of microscope is mandatory in this situation, allowing the observation of the canals mainly in the straight portion. The use of EDTA is initially not recommended because of the chelating effect may change the dentina permeability, leading to a false canal. This is a clinical situation which a mandibular premolar was referred for her intervention. In the initial X-ray, the canal line could not be visualized after the filling material located at cervical third only. The initial intervention was performed with ultrasonic tip diamond. After that, file C-pilot were used from tipper 6 to 10. I believe that in these situations, you should use number 6 files with oscillatory movements until you feel the file engaged into canal. Usually, disengagement means you reached the initial portion of the canal. When such situation happens, file should not be removed, and you should go on with the movement. At each 2 millimeters, the file moves to the apex. An X-ray must be taken to evaluate the direction of file's advancement. You will only move to the next file when you feel the file loose inside the canal. After reaching patency with a hand file, a rotary system was used to fulfill the preparation. In this case, the ProTape universal system up to the instrument F4 was used. Foraminal patency was reached using hand files, and the root canal filling was performed with single cone. The obturation technique used A8 plus sealer with continuous wave of condensation. This is the final X-ray showing the tooth with a provisional post and crown. Further, the complete filling of the root canal system with an apical delta obturated. This slide depicts a retreatment clinical case presenting great difficulty in reaching full working length. After gutta percha removal and to obtain patency in full extension, the C-pilot files from 6 to 10 were used in oscillatory kinematics as seen before. While attempted to reach the root canal patency with a size number 10 instrument, a separation of this file occurred inside the canal. But I used a new file, number 15, with continuous irrigation and oscillatory movements aiming to bypass the separate instrument. After bypassing, long and thin ultrasonic tip was used and the vibration allowing the removal of this fragment. So, foramen patency was fulfilled with the size 15 instrument. Next pictures show root canal filling. A tapered cone plus accessory cones followed by vertical compactation of these cones. Tooth was sealed with temporary composite resin. The patient and the referring dentist agree in not removing the crown, and after 6 months, there is a tendency of bone reeling. Now I will introduce the removal of post. Initially, I will talk about anterior teeth. First step is to perform meticulous evaluation of the X-ray. Innate failures in adaptation between post and root canal walls might be observed. After crown removal, we must turn post anatomy from conical to cylindrical, allowing the exposure of cement used to post cementation into the root canal. In the exposed cement, a tiny, long spherical drill or a thin ultrasonic tip removes the maximum amount of cement laterally to the post. In this image, we can observe a satellite ultrasonic tip 5AE. This tip presents appropriate characteristics for post removal. It is very important to have a cylindrical shape, bending, and with rounded point. As mentioned before, it is necessary to observe failures between core and root canal walls. Moreover, it is important to assess the kind of post inside the canal. Metallic post, screwed post, or a fiberglass post, each kind will require a different approach for the removal. Many colleagues are very concerned about post length, but eventually long posts present a poor cementation and consequently are not difficult to pull out. In this video, a step-by-step removal of a metallic post is observed. First, we see the change of core anatomy from conical to cylindrical. Subsequently, there is the action of long and thin drills and the thin ultrasonic tips at exposed cement areas. After that, The 5AE tip or similar is used at middle third of the core. 50 to 70% power range is used, always with simultaneous irrigation delivered by the same device. The touching area of the ultrasonic tip between post and tip must be changed frequently. When an adaptation failure between post and root canal wall is located in the mesial aspect of a root, for example, the ultrasonic must be used at the opposite side. This principle stands for the propagation of ultrasonic waves. The simultaneous use of two different ultrasonic devices and two different tips allow a synergic effect of both, decreasing the required time for post removal and preserving the safety. This is a good technique for more complex cases. If two ultrasonic devices are not available, a mirror rendering may be used with the same synergic proposal, but it is not provided the same efficacy. This image presents both pre- and post-operatory X-ray after placement of new cores by the general dentistry who referred the patient. Final X-ray on left and a follow-up after 6 months on the right. Bone reeling in periapical area of both teeth is observed. There is a great concern in the multiradicular teeth when 2 or 3 posts are present. First step should be section the core with a transmetal or a cylindrical carbide burr. This procedure separates the core and consequently the intraradicular retention. You should always initiate the removal with the smaller post, allowing a better access of the greater one. Great attention must be paid to the coronal portion of the large posts. The shape of the coronal portion should be modified, enabling the explosion of the sealer on the base of the root and helping the remotion of the core. This particular case presents 3 posts, 2 mesials and 1 distal. The first section was done in buccal-lingual direction to separate the distal post from the mesial post with transmetal burr. A second section of the mesial post was done in order to remove mesial posts one by one, and after that the distal post was pulled out. The image shows the clinical aspect after removing the post and the process of root canal filling removal using reciprocant instruments. This final X-ray shows the final obturation and the post space created. The following video shows a screw post removal. The touching of the ultrasonic tip must be done in a counterclockwise manner, allowing this way the unscrewing of the post. This is a different technique, especially used in this procedure. Fiberglass posts require a completely different approach because it is not possible to use ultrasonic vibration at the coronal portion of the core. This article, published by our group of professors, 3 techniques for fiberglass post removal were studied. It is important to mention that the coronal portion must be removed with conical diamond burr. Only the intravascular portion will remain and will be removed using the described technique. Among the 3 different techniques evaluated, the best performance was reached by Group 3, demonstrated on the following slides. In the following pictures, the technique is presented after the crown removal and the coronal portion of the fiberglass using a conical diamond burr. A spherical diamond burr number 1 was used to create a hole of about 3 millimeters. Thereafter, a diamond-tine ultrasonic tip is used, applying in and out movements in order to obtain penetration through the fiberglass post. The procedure continues until the gutta percha is reached. There must have alternation between the ultrasonic tip with and without irrigation, and a mild reaching of the post is desirable, allowing the access into the fibers. This clinical case shows the initial treatment on the tooth 21, which in this picture is the one from the right side. The patient reported sensitive pain on palpation after 6 months follow-up. In spite of the normal radiographic aspect, reintervention was the treatment of choice. The already mentioned technique was performed always under microscope magnification. After post-removal and root canal shaping, copious irrigation with sodium hypochlorite at 5.25% was performed with rotary instrumentation. Calcium hydroxide was used as intracanal medication during 1 month. At the next appointment, the patient was asymptomatic. A new filling and another fiberglass post was done. The next step is about removal of separate instruments. After the identification of a separate instrument, copious irrigation is done. We create a path using Gates-Glidden burrs and irrigation with sodium hypochlorite. It is possible to use diamond ultrasonic tip too. These steps create a periphery allowing the reaching of the instrument. Thereafter, a tiny hand file is used under oscillatory movement, reaching the overlapping of the separate fragment. Copious irrigation is done, and when the instrument touches beside the fragment, it should not be removed, and the movement must continue. After bypassing the separating instrument, and the ultrasonic tip is used to slightly touch the fragment in counterclockwise direction. This purpose is to remove the fragment. In some cases, it is only possible to bypass the separate instrument. That is a clinical situation presenting a separated instrument at apical portion of mesiobuccal root canal. These images shows the profiling previous to the separate instrument. The image presents the removal of dentine in direction of the safety area, avoiding the risk of damaging of the furcal area. Very careful, it is also create a small path towards the risk area. This is the moment in which the RAND file bypasses the separate instrument, always using oscillatory kinematics and copious irrigation with sodium hypochlorite. In this case, the instrument could not be removed, but it is possible to obturate up to the end of the root canal. This can be seen at the final X-ray of the case. This paper, published by our group, analyzed the success rates for removing or bypassing fracture instruments. The study concluded that when it is possible to see the fragment under operative microscope, the success rate doubles. As an example, when the instrument is not located at the curved portion of the canal, the possibility of removal or bypassing is 2 times greater than when it is not visible. In this clinical research, the average rate of removal or bypassing was about 7.5%. This demonstrated that we have a great possibility to achieve success even in situation of a separated instrument. Another clinical case showing separate instrument and the bypass is observed using the already described technique. This is the root canal filling of this case. We can observe that the removal was not possible in the final X-ray. To remove silver points, we are use the same technique that was explained to separate instruments. Finally, to finish this lecture, I go over the key points to obtain success on the endodontic retreatment. I suggest dentists focus on full knowledge of anatomy and keep on practicing new technologies. I would like to dedicate this lecture to my wife Vanessa and my daughter Yasmin, who have motivated me along my career and make me happy. I included my contact information on the bottom. I'm happy to answer any questions by email, for example. Thank you.